I'm going to introduce myself and get started because we've got a lot of interesting things to cover. And I'm Dr. Doris Greenberg. I'm a developmental behavioral pediatrician in Savannah, Georgia, and on the faculty of the Mercer University School of Medicine and the Department of Pediatrics in our brand new sparkling children's hospital. And I've been in this field for 50 years and been a doctor for 56. So there you go. We're going to talk today about the things that are commonly seen in your practices. And the only disclosure I have is that in the past year, I have consulted for Ironsure's pharmaceutical company, but taken no money or compensation from them. They've just asked me questions and I was able to give them some information. Okay, but this will not have any bearing on my talk. Let's get going. Let's see. Enter. Why is this thing not going, John? Oops, let's go back. Okay, next. All right. Hopefully, we're going to talk about things like speech and language and important milestones that are very important to know for doctors so that you know what to say to families if children are not talking on time, and signs of early autism. We're going to talk about hearing losses, which are very common. And if you were asked today, what's the most common cause of hearing loss? It's iPods and iPhones and headphones and too much noise. We're going to talk about autism specifically. It's so common. And after listening to this, hopefully, we will be able to talk also about visual and hearing troubles as well. So we'll start with hearing. And it's a good thing because today I went upstairs and had to get my hearing aids back in because I have Bluetooth. I'm a modern woman, and it's very important to be able to hear. As I've gotten older, my hearing for high tones has gone away. And so now they're augmented and I can hear sopranos and high children's voices. So let's talk about that. Hearing impairment. Probably one of the most common things that we see are conductive hearing losses, because what happens is people get otitis media, they get problems with the eardrum, with fluid behind it, or they even get difficulties with the ossicles from some disorders. But the commonest thing that causes a conductive hearing loss is serous otitis media. And when we see sensory neural hearing loss, we're talking about things that occur in the inner ear, the cochlea, the auditory nerve, and the brain pathways. Many children have a mixture of loss, and adults as well. I have had a few patients who've had cortical hearing loss, but very rare. These are kids who had bleeds in their brain, and suddenly after the bleeds, they were unable to distinguish what they were hearing. Very rare. Hearing problems, when you see sensory neural hearing loss, you've got to think genetics. That's the commonest thing. And why is that? Because in years past, people with sensory neural hearing losses often met each other at schools for the deaf, and they married, and their genetic disorders, many of which were recessive, were then created in offsprings. Prenatally, hearing loss can occur in about 10%. Around the time of birth, 5 to 15%, especially if they have infections during the newborn period. And infections, head trauma, and especially the ototoxic medication exposure can give 20 to 30%. So if you look at everything, a sensory neural hearing loss is primarily genetic and oftentimes recessive, but because of matings at schools for the deaf, they occur. Nowadays, we don't have so many schools for the deaf, and I would dare say that we will probably have fewer of those. Remember that the aminoglycosides during the time of birth or after can lead to quite a few hearing losses. Now, what kind of hearing tests are you going to order? And always know that what you're going to order, you'd better know what you're going to do with the results. The little click test that's done in the nursery usually tells you that the circuitry from the cochlea out is okay. It does not tell you what the brain is doing. So that a hearing test in the nursery can pick up hearing losses in some and get things started so that they can be remediated. But the best test that can be used afterwards in a child where you're not getting language development, where the child does not seem to hear, would be using an auditory brainstem evoked potential, which uses an EEG, so it does not require a lot of cooperation. A child can be sedated even and have that done. If you're going to do audiometry, judging from what I've been through when I've had my hearing tested, you really have to cooperate. You have to follow the directions. And just because a newborn test was good does not mean the child is not deaf. But it does mean that if it is abnormal, you get started doing all kinds of things to remediate this child's problem. And in today's world, it's very wonderful that we're now doing cochlear implants at a very early age, to the point where we're not seeing a lot of people walking around with a very abnormal deaf speech. Very important to look in the ears. I can't stress that enough. Of course, having a big lump of wax in there certainly can impede hearing. And tympanometry, if the child will cooperate, will show you if the drum is able to wiggle back and forth when the pressure is put in the ear. And that shows whether there's serous otitis behind it. Hearing tests only show the ones in the nursery, the integrity of the outer hair cells. And even if there's an acoustic neuroma or something in the nerves, it does not tell you anything. So if there's a lot of noise in the nursery, lots of beeping, lots of ambient noise, that might not be a very good test. Tympanometry does not tell anything about any hair cells or the nerves or the brain. It should be part of the overall hearing evaluation. But to do audiometry, if you have a patient, like some of my autistic patients or some of my patients who are like jackrabbits running around the room, they may not be able to cooperate, and you may not get a really good idea of their hearing. The pediatric ENTs and tympanometry technicians, for example, have some cute little gadgets that they can use to distract a child. But if a child can't pay attention to the test procedure and listen, you're not going to get an accurate test. So if you have a very active ADHD patient who cannot sit still, getting a hearing test on that child may not be very valid. And if the child fails the hearing test, get them to a pediatric ENT or person who does hearing evaluations so that we can get a more accurate test. The auditory brainstem response can look normal, even if you have an acoustic neuroma, and there are false normals. So you might need to repeat evaluations. If a child has had hearing problems in the past, repeat the evaluations up to 3 if a child's had the medications that are ototoxic. Every patient with meningitis should be tested for hearing on discharge and also at periods after that. The neonatal infections like CMV, toxoplasmosis, syphilis, jaundice, severe jaundice, and acidosis may also cause deafness. And syndromes like neurofibromatosis, or people who have a family history of permanent hearing loss, and children who've had head trauma, think football. Make sure that you check the hearing. And it's the number one answer if you're on the boards. What's the first thing you do if you think the child can't hear? What's the first test you do? You do a hearing test before you check language and everything else. That's the first go-to, and it's very, very easy to get done, and it's inexpensive, and it's very valuable. Now, obviously, congenital hearing loss is present at birth. It may be hereditary. You'll often find when you take the history that there are people in the pedigree that have this. Infection during gestation can do this. I remember that German measles went around when I was a freshman in college. I got it first, and the rest of my dorm came down with it too. But everybody in my school that year, all the women who got it, and we had thousands of cases, nobody had a child who was born with hearing problems. Newborn screening really pays off for these children who have poor hearing at birth, and we can get started getting them outfitted so that we can get augmentation and any kind of surgery to give them the chance to talk and to hear early. Autosomal recessive inheritance is more common for about 70 to 80% of cases of hereditary hearing loss. There are a lot of syndromes. My goodness, you could spend weeks trying to learn them. But here's a good one that you need to remember. If you run over a cat and you pick up this dead cat and you look in its eyes and you see that one eye is blue and one eye is brown, and you notice that there's a white forelock on the head, this cat had Waardenburg syndrome, which comes with deafness that develops over time. Anything that affects the first or second arch can also cause this. And things like Treacher-Collins and Waardenburg syndrome, they're autosomal dominant. Jackie Kennedy had Waardenburg syndrome, but she was not deaf, but she had the hypertelorism, the white forelock, and she did not have different colored eyes, but if you look at her face on, you will see that. Syndromic deafness is just part of the whole syndrome of children. I have children who have deafness and renal problems and other problems. Remember that the kidneys and the ears are developing at about the same time. If you see an abnormal ear on one side, check the kidneys. Acquired and prenatal period, think of all the infections. The hearing loss can be progressive and can continue after birth. Toxins like alcohol and mercury, and also probably lead, can also lead to hearing loss. At the time of birth, we are now saving babies who are micropreemies. Extremely premature babies may have an increased risk of loss, not only of hearing, but of vision as well. Add to that hypoxia and acidosis, the high bilirubins and the hypoglycemia, noisy environments, which have been reduced a lot in neonatal units, the aminoglycosides, that's a biggie. And remember that one, and always think meningitis, always. Postnatally, it's back, mumps. Our anti-vaxxers are going to show a whole new retinue of diseases that we thought were eradicated. Mumps is back, and mumps can cause hearing loss. Whenever a child or an adult has meningitis, it behooves you to get audiology after the infection. I have several deaf patients who are there because they've had meningitis. Years ago, when I was a young resident, we had wards filled with meningitis, which I'm happy to see does not happen often, but you always have to think of it and not miss it. Prolonged exposure. I can't express enough emphasis on this. Pronounced exposure to loud noises can cause deafness. You can ruin your hair cells. If you're in a car and the car next to you is vibrating so loudly that your car is vibrating, you can bet that that person's hair cells are going as you listen. They are people who in their 20s now are wearing hearing aids because they have destroyed their hearing. Infections and abnormalities of the ears, canals, drums, and ossicles always have to be thought of. But remember, the commonest things happen most commonly. So if a child is using headphones, and now with virtual schooling they are, and you can hear them across the room, then it's too loud, and you've got to tone it down. I just think that in some families, the noise is so high that everybody is getting hearing problems, and that's a problem. Now, when is it that hearing loss is most upsetting and most profound? Prelingually, before the child is 2 to 3, if you can't hear, then you're not going to develop the speech pattern like a child who has already heard speech and then gets a hearing loss. Another pearl, unilateral hearing loss is not going to delay language and speech. So if a child has a 40% loss in one ear and the child is not talking on time, look for other causes in addition. Again, in big letters, just because a patient passed the newborn hearing screen, it's still worth your while to repeat the evaluation before going into any developmental language or speech delay. Hearing test should be done first before anything in a child who's not talking on time. Remember that even a deaf baby will make babbling sounds. The trouble is they're not reinforced by somebody because the child can't hear that. And so they will have a delay in speech later, but they will make sounds. They'll babble. They'll say da, 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 and ba, 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 ba. And it's easy to miss that there's a hearing loss in those children. And before we go, I'm going to test this out. 2 questions. Okay. Let's see if we can answer this live. I'm not seeing anything, so I'm going back. Okay. And if I'm technologically challenged, please forgive me. Next. Whoops. Okay. Talking. This is the biggest reason I see children who later on turn out to have things like autism or cognitive disabilities. Speech and language probably are the biggest predictor of how you'll do later in school. That's another pearl. Even newborns have language. A mother, for example, can tell if her newborn is having a hungry cry or a pained cry, or is just sleepy and needs a nap and hungry. And that they're all different and they're all communicating. A child should be cooing and smiling by 2 months of age, usually earlier. Doctors' children even earlier than that. Reciprocal vocalizations can occur. You carry on a conversation with a 2-month-old. You can say, hi, how are you? And the baby goes, back to you. There's a give and a take already. 4 months of age, babies are laughing, squealing, making their voices go high and low. And when you walk in the room, these symmetrical beings will shake their arms and legs in mirror image of themselves, and they will laugh and squeal. That's my dog who's illustrating that. This is a very important one. 6 months of age. Does a child turn to a sound or voice? And actually, most children will respond to their names and turn immediately. And they may begin to imitate speech sounds. At 9 months, so before they're every year, they're usually saying something like dada or mama or baba. And if they're not understanding their name and recognizing when you call it consistently, that's a red flag. And that should be followed up with testing. Nigel, be quiet. Okay, that's my dog, Nigel, and he's 14, and he's a senior citizen like I am. If you see a child at a year and the child is not babbling, even deaf children will do this. You need to check it out. At 1 year, most children will have something equivalent to mama and dada and another word that has meaning. My son said the, and he would point at things and say the, and he meant that. By 15 months, we've only gotten 3 to 6 words, but that's significant. And they will point for what they want. There are 2 kinds of pointing. First kind is as if, look at that, look at that, look at that. And that they don't turn around and look at your face to see if you're reciprocating. They just want something and they will point at it. That's proto-imperative pointing. More sophisticated is proto-declarative pointing, where they point at something and then, like window shopping, they'll say, and you look at the mother and then you look back. That is a real predecessor. That's really what presages the development of speech when they start doing proto-declarative pointing. So in the first year, you get a couple of words by a year, 3 to 6 words by 15 months. And by 18 months, they should be really doing much better with that. They start using many more words, 7 to 10, and usually things that they want: juice, more, car, baby, cookie. And in most households, they can identify body parts. If you say, where's your nose? Where's your ears? They can do that. And if you're a child of a doctor, you'll know your axilla and your umbilicus. I remember our child learned those. By 2, this is a good mnemonic. By 2, you should have 2 to 3 word phrases. If you remember, if any of you have traveled abroad and you go to a country that uses a different language, your receptive language comes first. And so before you can start speaking, you have to have at least 50 words to make any kind of a phrase. They begin to use pronouns like mine, and they will point to pictures in a book. If a child is 2, and there are no single words, get the kid to somebody to check the development. Don't ever say, don't worry, he'll talk, he's just a boy. I hear that every day in my office, and it's heartrending because these children could have gotten services earlier and changed the trajectory of their development. Never hesitate to ask what he's saying. Flirt with a baby, talk to them, see if they talk back. If you bring the child into the office and while you're taking the history, the child's babbling away and doing things, record that. It's very nice when you get natural speech and language. How should you be able to understand them? By 2, you can understand about half of what they're saying. The mothers can understand more. By 3, 3/4 of what they're saying. And by 4, all of what they're saying should be understood by other people besides the mother. A child who doesn't make a 3-word sentence by 3, that's not a good thing. And so 2 words, 3 words. By 3, they have a lot more words. They use plurals. They understand 2-step commands and 2 prepositions, like put it under the chair, put it behind the chair. And by 4, this is when the who, what, when, where, and why questions can be answered. And this is very infuriating for parents because the child is often saying why for everything. Language development predicts how they're going to do in school. Much better predictor of future cognitive functions than anything in the motor development. I've had children who are so hypotonic they can't get around, but they have language and speech that's phenomenal. And remember, intelligibility, 2 out of 4 at 2, 3 out of 4 at 3, and 4 out of 4 at 4 years. Now, what things clue you in that raise your suspicion that there may be autism? And we're going to talk more about that in another section, but I want to emphasize this because 1 in 40 to 46 people now has autism, and we're finding subtle signs of this. Failure to talk is the biggest reason they come to me. Odd patterns of talking, like quoting from movies, but not using the speech to ask what they want. Lacking gestures, robotic speech, people who talk like they are on a subway train telling you the next stop, using a sort of a mechanical voice. Prosody is the musicality of speech that makes it go up, makes it go down, gives you rhythms, and they have poor prosody sometimes. Those things should raise your suspicion. Aloofness. A child who comes in the room and doesn't look at you like, what's he going to do to me? I would worry about that. Or the child who just looks through you. Or the child is more interested in the patterns on the wall than in what's going on. And kids who may have speech, but it's not used appropriately. It's not useful speech. Kids who jargon later on in life and making all kinds of babbling sounds when they could be saying words. This big one is failure to respond to the name. A child comes in with a parent and I immediately call the name and the child turns around. That's a good sign. Child doesn't. We try it several times. I have the mother call the name. I have the father call the name. And if the child doesn't do that, you'd better get a whole workup for that. There are lots of quotes from movies or TV. I have mothers who tell me the child has memorized a whole Disney movie and can quote everything from it, but can't ask for a drink of water. And here's the big one. This, covering the ears when others are talking. or the child who comes into you wearing headphones because he can't stand hearing other people. These are atypical. Don't pass it off. Get it checked. And what do you say to the parent? I'm really concerned about that. I wonder why he's doing that. It looks a little atypical. I'd like to have it checked out. No one will hate you if you get it checked. Everybody will hate you if you miss it, because the longer a child goes without treatment, the more difficulty that ensues because you've gotten off track, and it just leads to being off track even more. It's interesting, speech and language disorders run in families. I had a child who came in speaking like Elmer Fudd. When I interviewed the mother, she spoke like Elmer Fudd, and so I saw why the child spoke that way. But if asked, what do you do first? You all are going to get it right. You're going to say, check hearing. Consonant sounds may be abnormal until age 6. You hear kids who go to cool instead of school, or fish instead of fish. You assess for speech and language disorders in children who are acting out. Many children who can't express themselves will do everything to get understood, including yanking on your clothes, making wild gestures, and they get very frustrated if you can't understand them. So when you get a child who is having problems with speech, they may have attending problems with their behavior because they're so frustrated. That's why getting them into speech and language therapy early and getting communication devices if necessary may make a huge difference. Now, you should know these terms: receptive and expressive language. The receptive is what you understand, and the expressive is what you can express. Phonemes are the smallest unit of sound that change the meaning. So cat versus pat. A morpheme is the smallest unit of meaning in language. So if you put an S on something, it means a plural, all right? Book versus books. Now we put words in syntax, combining them into sentences. And when you have odd sentences, that should raise a flag. Semantics is the meaning of words and sentences. And being pragmatic is to use this language socially. So it has use for you. Some kids will just say all kinds of phrases, but it doesn't necessarily mean anything. So when you see a child, you think about the intelligibility of the child's speech. How fluent is that child? Now, all kids will stutter when their brain is going faster than their mouth at about 3 or 4 years of age for a short period of time. It's like the salesman who gets his foot in the door. The child will say, mama, and then mama, 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 until he can say what he wants because he's gotten her attention. Fluency is important. Stuttering should be followed. If the child continues to stutter and has to screw up his face and make all kinds of contortions trying to get those words out, those kids can have lifelong problems. Our president has stuttering. You can hear him do it sometime. He overcame most of it, but it's still a very difficult thing to go through. If you have a child who has a nasal kind of a voice like that, think of possible adenoids, which is a common thing, and those kids will often come in with their mouths open. Also, if you have hypernasality, put on a glove, insert your finger in the soft palate and make sure there's not a submucous cleft palate that could be there. Vocal nodules are common, and unfortunately in athletics, the coaches and others are screaming out on the fields, and the kids are screaming, and they get vocal nodules, which can be quite disabling, and may need to have surgery for those. But voice rest is the first thing you do for that. Now, this is something that's often mislabeled. What does it mean for speech apraxia? There are some kids and some adults who just can't get the words out of their mouth with their lips, tongue, and shaping of the mouth. It's like cerebral palsy of the mouth. They can't make appropriate speech. Now, they can control their mouth movements for eating just fine. They're not choking. They can digest things. They can chew things up and swallow. But when it comes to the brain telling the mouth what to say, it's very, very difficult for them. These kids grow up and have lifelong problems. They will do everything they can to be able to be understood. So they have lots of gestures. They look like they're playing charades with you every time they try to make sounds. They'll often have some pat sounds that they can make, but they're socially engaged. There's nothing wrong. They're not aloof. They turn to their name, but they can't get the words out. And they desire to communicate. They can reciprocate with you, but they are so mortified that they can't get this out that it oftentimes comes with later behavior problems. Normal children, as I said, between 2 and 3 will have the mind going too fast for the lips, and you'll see some stuttering. But after 5, remember 5 is important, refer for a speech and language evaluation. They grimace, they have all kinds of facial expressions and head movements, trying to speed up the flow of speech. It's very painful, and if you're a parent watching them, you want to talk for them. So those children should not be neglected. You should get them into a speech program. Many times the schools will refer them for speech on site, and it is a very disabling thing. For correction, there are camps and other programs that actually will help stuttering. It's interesting, I have a boy in my practice who stutters terribly, but when he sings with the guitar, he sings with perfect fluency. So he's become a musician, and everybody likes standing around him, and that's how he's getting his popularity. Here's something that you're going to see a lot. It's so common and yet so missed. Children who are selectively mute. They come into your office, they sit there. I usually ask them if they're married. I usually gets a chuckle out of a child who's normal. And they look at me and they immediately koala bear themselves into their mother. And they refuse to talk to strangers like me. They won't talk to the doctor. They won't talk to teachers. They turn to an adult to talk for them. Yet at home, they're talking a blue streak. They're fine. And so I ask parents to please record a little vignette of them talking. But this child will not speak when asked in class. The last thing this kid wants to do is be in the Christmas show. It's a challenge for teachers to get them to perform in class. The anxiety is huge. And these children will not order for themselves in a fast food restaurant. They won't pick up the phone if they don't know the number. And these kids are absolutely terrified of talking. When it gets to the point where it's so fearful and so impairing that they can't make it in school, they have social phobia, we may actually have to treat this as an anxiety disorder. And in children over 6 who have this, we oftentimes will use a small dose of sertraline, Zoloft, which may help a huge amount in helping them be less phobic. And I get at least 1 to 2 of those a week. And when I ask a question, they just absolutely will not answer me. They won't look at me, and they like the ostrich putting their head in the sand. Okay, kids who don't look at you. Well, always remember that just like hearing loss, there are visual losses. About 1 child out of 1,000 has low vision. And the vast majority, if you're asked on a test, would be prematurity as a cause, or other developmental disabilities. 1/3 of them are preemies, and 2/3 of them have 1 or more other developmental disabilities. It's very important to pick up visual problems early, because the brain will shut off double vision if you have strabismus, for example. And unless this is treated early by an ophthalmologist with patching or dilatation of the good eye so that the other eye takes over, you can have amblyopia later where that one eye doesn't work, and God forbid you get an eye injury in the good eye, child is blind. So any child who has to be patched, I would suggest that child needs safety glasses along with other children if they're helping to mow the grass or do something that might cause any kind of danger to the good eye. And the patches are very helpful, but many children find them awful. So you can buy patches in this country that have absolutely gory looking pictures on them that the kids love, and they'll wear those and avoid taking them off. Now, blindness in children, prematurity and CNS bleeding and hypoxia, big causes. I had a friend who had a baby, sent me a picture of the baby. One eye had a white reflex, the other one had a red reflex. I didn't know what to say, except I talked to my husband. He says, we got to tell her. So I called her up and I said, you've got a gorgeous baby, but I noticed a little abnormality in the picture of the eyes. Can you send me some more pictures of that? Because sometimes there are conditions that can cause a growth in the eye. You need to get that checked. Well, sure enough, the child had a retinoblastoma. I felt terrible, but we caught it early and the child was able to avoid getting it in the other eye. And the child is now grown and doing very well. Infectious diseases in the mother are common and getting more common as non-vaxxers are in our lives. Toxoplasmosis, rubella, syphilis is still there. Always think syphilis, AIDS, cytomegalovirus. And remember, cytomegalovirus is still transmissible even after birth. And so if you have a young nurse who's working with a baby who has cytomegalovirus, that nurse can come down with that and have children who might have visual problems. Nervous system diseases can cause blindness. Retinopathy of prematurity is so much less of a problem now. So many of my kids who were micropreemies don't even wear glasses. They used to have very thick, heavy glasses. And now with laser surgery, they're doing much better. And with neurologic disorders and trauma, cortical blindness can occur. And remember, if you see somebody who suddenly goes blind, like the soldier who was in a war and suddenly goes blind and can't be put on the front lines because he can't see, always think of conversion disorders, which can be very real to the patient, but actually there is nothing neurological to explain it. Finding amblyopia, 2 to 3% of kids have this. So it's a common reason for visual loss, and treat early with refraction and patching. And the brain is still receptive. It hasn't closed down. So there's a critical time period in which you can do this. And after a certain age, it won't work. What are the signs that a child might not see well? They rub their eyes a lot. They have a lot of tearing or photophobia. That white pupil that I talked about could be retinoblastoma. Seeing extremely close to see something like this and not tracking, eyes tracking together, strabismus. And remember, you see this, you are not wrong for getting this child a more sophisticated eye exam. Send the child to a pediatric ophthalmologist if you can. Optometrists often prescribe glasses that might not be necessary, but the ophthalmologist has no interest in prescribing glasses until they're needed. By the way, children who get glasses that really don't need them will break them very quickly, and you'll have lots and lots of broken glasses at home. Newborns, what do you do with a newborn? To check their eyes, you look at their response to light. You look for opacities like congenital cataracts. Anybody who has had a difficult neonatal period needs a formal eye exam when they are checked out. And by 3, there are nice little tests that you can use that have pictures instead of the E on it. And by school age, they can track things and show visual acuity in eye charts. Periodically during school years, school nurses are great about doing the Snellen tests. And any child who complains they can't see the board needs an eye exam. Even if it was good last year, they need another one, especially during the teenage years. And a full eye exam is indicated. Avoid traumatic eye injuries. It goes without saying that you want to keep these children from having problems in terms of injuring their eyes, martial arts. Good God, sticks and swords. I remember my mother saying, be careful, you'll poke each other's eyes out. Pucks or balls, severe eye injury. If you have ADHD kids who aren't paying attention in baseball and they're in the outfield and the ball's coming to them and people scream, the ball's coming, and they look up, they get an orbital fracture. I've had several of those. Protective eyewear is very important for hockey, paintball. Anytime you have limited vision in one eye, protect that other good eye. Visual loss. It's interesting. My piano teacher used to say that her favorite pupils were her blind pupils. They have a little bit of difficulty imitating others as easily because they're missing the visual cues. They may have less ability to appreciate the exploration of the environment, be able to orient themselves in space, and they will depend on other senses, which may be heightened. I can't say it enough. Early intervention is extraordinarily important, and the Association for the Blind is wonderful. They have all kinds of marvelous things that will read everything to it. Every one of your computers has accessibility options that will read to you what's on the screen. My computer came already with that on, drove me crazy. It talked about every keystroke until I could get it off. There are speaking computers, magnification devices, and talking books, and all kinds of wonderful things you can get from the Library of Congress for nothing if you write a note saying that they are disabled. Braille is still being used. There are reading clubs and early books to teach Braille, but I think that's going to go out after a while because now with all the accessibility options, they don't need to have special books printed in Braille. They can actually listen to things on disc, or they can have computers that read to them. Now, this is important because there are an awful lot of charlatans out there who are doing all kinds of eye training exercises because kids around 6 years of age to about 7, many children still reverse their letters, and this makes parents think they're dyslexic. If a kid can't read well and is 2 years behind where he needs to be, that's dyslexia. But eye training exercise won't do a thing to correct this. And there are kids going for $50 a pop or even more, many times a week, where a person watches a ball go across a screen and they learn to focus on the ball. They get good at focusing on the ball. Nothing happens with the reversing of letters. Putting children in schools for the blind or for the deaf really may prevent normal socialization. That's why we try to mainstream these kids. And blind children, if they are mentally okay, they have no problems with language at all. The only delay that you may see is some motor delay because they're a little bit more afraid to explore because of their lack of spatial orientation due to their vision. Okay, cry with me. I'm trying to give you some organization here. It's not easy with all the topics. This has nothing to do with what we talked about, but boy, is this common, and you're going to get it in your practices. What happens when when the parents divorce or separate? The developmental stage of the child really determines whether or not the child will react in a certain way. Unfortunately, in every household, children disobey their parents, and they think of times when their parents got mad at them. So young children will often think they caused the divorce because they were bad. Another thing to remember, if a parent remarries, this destroys that fantasy that children have that the parents will someday get together and live happily ever after. Even adults whose parents divorce think of that fantasy. When a family remarries and there are other children that have to blend with them, there are many factors. It's not like the Brady Bunch. Child may feel abandoned because no longer does that child have the single parent's ear, and privacy with a single parent from before is lost. New homes, new sibs, new parents, new locations, new schools, new discipline. Creating a family routine is probably the most important thing that you can tell your families. Get supper at the same time, develop a routine at breakfast, having the biological parent be the disciplinarian for the child if there's a blended family. And it takes a while before you get to like a person, and it takes a while before you get to love a person. So automatically, if a child doesn't like the step parent, it's going to take time. And what you have to do is establish trust, and you have to establish affection, and it's going to come with evidence that you are doing these things. Now, a child of divorce who goes back and forth between different parents should be told, I'm your doctor. I'm not your mother's doctor. I'm not your father's doctor. And if you're a family doctor, you may be all those, but I'm here to represent the child and what's necessary. No child should be a messenger back and forth. You're not expected to tell me what daddy does when you're with him or what mommy does when you're with her. And if you're asked, you say, I'm not a messenger. Children are not spies and should never, ever be adultified, should never be made into a co-parent. You're not the young man of the house after the father leaves. You're not the young woman of the house after the mother leaves. You are my kid, and that's all I expect you to be. And sometimes you're going to be naughty, and I understand that. No matter what age, a child has a fantasy that the parents will reunite, even if you're in your 50s and your 70-year-old parents broke up. That remarriage breaks that fantasy. Children, as I said, you don't make them the man of the house. And the worst outcomes occur when they're still shooting it out after the divorce. If you have a family that's constantly going back to court over every little thing, I can assure you that the children will have behavior problems. Remember, you are the advocate for that child, and you have to advocate for the child during divorce. I just got a call today to do 2 depositions about children whose father left the family and what their needs are going to be in the future. The court decreed visitation is terrible. You can't make a child have every other weekend just so that they can still go to birthday parties and things like that if they have mandated visitation. Inflexible visitation is really awful on the child, and families should work out a system where they can be flexible enough so if a child has an event or if there's a sickness, the child doesn't have to leave. I have families that wait till 6 o'clock sharp before they'll let the child go for the weekend. And at 6 o'clock sharp, if the child's not back, there's all kinds of legal stuff that goes on. That's going to cause the child to have a lot of problems. Mediation can help a lot, and I advise it. I almost got thrown out by the Trial Lawyers Association for recommending this, but this does work very well. Now, another thing we need to cover are the stages of grief, and you all know it because you see it. Dr. Kubler-Ross, I had the chance to study with her, and she came up with these steps that still resonate today. When you go through grieving, the first thing that happens is you almost have a, I can't believe it happened moment, or you can have an I can't believe it happened for months or even years. If you're still in denial for longer than a month, there's a problem. After that, there's a lot of anger. Why did this have to happen? The doctor's a quack. The patient was perfectly well until he had that gastroscopy. Anger can be reflected on the doctor or on other people. And then there's sadness. Following that, you begin to say, well, if I could just make it to Christmas and not go to pieces, if I could just make it past his birthday, you begin to bargain. And finally, you find yourself in a recovery period where you're not laden down with grief. If acute grief occurs beyond 2 months, you need to get some help. And doctors are really tough on themselves because they grieve too, and they don't often get help with that. Don't be afraid to ask for it. And the hospices around the country have excellent grief programs. They have one here in Savannah where they actually have a camp called Camp Aloha, where the children go for the weekend and do all kinds of things, talking about the people who they lost, making tributes to them, finding each other's comfort because they share a commonality. And it's been very good for some of my patients who are really stuck grieving. Before age 6, many children think that death is not permanent, that if all goes well, they'll come back happily and person will come alive again. And then later, when they get up in their later years, around 10 years of age and above, they really see the finality of death and then they grieve differently. The thing that you have to remember is this. If somebody dies in the family, everybody in the family can go through the grieving process at a different speed. And what happens is one person may be still in the denial stage. It didn't happen. I don't want to talk about it. Another person may be crying a lot and being very, very sad. There may be an angry reaction that another person shows. So they can be out of synchrony. And little kids can grieve in very interesting ways. I remember my own daughter, when her grandmother died, made up a song. My grandma's dead. She's up in heaven. She's looking at me. Hello, grandma. This freaked out her nursery school. And I had to explain to the teacher that that's how she was dealing with it. And it was not freaky. It was on her level. This is also so important. Remember, when you go to graduations and you go to weddings and things that are big events in families, you'll often see that poor, sad family on the side with the kid in the wheelchair who are realizing that their child may not do these things, or the child who's very disabled. And they are grieving every time they get into a situation like this. This is a good time to say to them, I know it's really hard for you to go to these things, realizing that he can't do those things. And sometimes just that empathy can make all the difference in the world. Raising a disabled child, I'm sure you've all seen it because I've seen it over and over again. If you have a disabled child and you're raising a child, you will see a much higher divorce rate. And unfortunately, parents are very receptive to unorthodox, unproved therapies. The Defeat Autism Now group down in Florida that chelates children and puts them in hyperbaric oxygen chambers and does all kinds of heavy metal testing. They will fall for this. And I had a mother who came in, she had seen a doctor one time because her child was diagnosed with autism in my office. And between that visit and when she came back again, she had $10,000 worth of lab work done by the doctor. Parents are very vulnerable if they think there's something that's a long-term commitment. They will look for a sure cure, and family physicians and pediatricians can often prevent victimization. You don't say that's a quack, but you say there's not a lot of proof for this, and it's very expensive and it's very painful for the child. Things like chelation, I've looked it up and I found that a number of children have actually died from this. So we don't want to do that. And if you are a trusted physician, they will listen to you. Now, coping skills, you all know this, that parents with children with serious disorders need help, but so do the siblings. Never forget there's another kid sitting in the room and talk to that child. They may be overlooked while the parents take care of the child with big needs. Chat rooms and organizations may help. There may be also some crazy ones, but you should get a list of what they're looking at and be able to help them if they have questions about that. And a sense of humor. You get a family that can laugh. They can get through a disease much better than the family who's grim. And a good sense of humor may also help a child with a disability if they're being bullied. Some children are very easily victimized. Who's most victimized? The autistic kids who don't get it socially, children who are depressed, or children with deformities or disabilities. And there is a wonderful website that I refer you to called buddies.com. We teach patients not to be victims rather than rounding up all the bullies and punishing them. That doesn't do any good. This teaches kids how to be more resilient and what to say if somebody says, oh, you're so dumb or you're so fat. You can come back with a statement like, if you think I'm fat, you should see my cousin, that kind of thing. Now, relating to people, let's see. How to separate out autism versus other diagnoses. Remember what I said, speech apraxia has good social relatedness. They have lots of expressions. They don't have the atypical behaviors. They make every effort in the world to communicate. A child who's mentally slow, cognitive disabilities, we don't use the word retarded anymore, but intellectual disabilities, they will relate at their mental age. So you get a child who is about a 50 IQ, which means he's half of where he should be. He's talking like a 6-year-old when he's 12. The speech is present but less advanced. If they have profound hearing loss, they want to communicate with others. They will have good facial expressions and appropriate gestures and sharing. Just remember to look for that aloof child with atypical behaviors. Look for the autistic spectrum. And key ages that you should be evaluating them is 18, 24, 36 months. And again, remember, speech and language, really important. And you can have fun with these kids in a couple of minutes. You can get almost a whole developmental exam done just by playing with a child. Now, what to do, what not to do. A child who's not developing normal speech and language, you're going to give me that answer. 100% of you are going to say check the hearing, and always check for autism. Early intervention, such as applied behavioral analysis, where you have one person working with one child, rewarding the behaviors that you want them to have, just like puppy training, can change the developmental trajectory enormously. Immediate referral. You have a child who's not doing what you think he should be doing. Don't hesitate. Say, look, I might be crazy, but you're not coming back for 6 months. I can't let you sit there and worry for 6 months. I'm going to get you checked out. Never, ever, ever say, don't worry, he'll talk, or he's just lazy. Never do I see a lazy baby. Or we'll wait till the next visit next year and see if we need to do anything about this. And on the other hand, don't ever hang crepe either, like he'll never walk or he'll never talk. I had a 28-year-old autistic kid who talked for the first time and said, hello, Dr. Greenberg, how are you? After not a single word for 28 years. And never say he's just a boy, saying that boys are slower to develop. They may be slower to develop, but that's not an excuse for a child who's not talking. And he's just a lazy baby. Even a 50-pound 1-year-old can get up off the floor and walk. It's not because he's big. And so it behooves you, you've already learned these things, I'm sure. If there's a developmental problem, you do it immediately. You counsel the family about your concerns. You help them navigate the unorthodox therapies. Don't tell them they're crazy. Don't tell them the stuff is junk. Just say, I've researched this. It doesn't seem to help and it could be toxic. Prepare them for the transitions that are going to make them sad. Sexuality, separation, and independent living in the future if possible. Proactive medical home. You guys in family medicine, you're the quintessential medical home. I refer my older patients for their medical care to family medicine because the internists often leave my patients sitting on the chair while they talk to the mother. And you are much better at this. Proactive medical home, being available when they have concerns, and look for abnormal child rearing signs, especially in those people with developmental disabilities, because they could have abuse or neglect. Now, here's one thing that you can see oftentimes asked on exams: the vulnerable child syndrome. A child whose mother comes in with a child, and every time the kid passes gas, she's sure the child has got an ulcer or something much worse, wants lots of medical care, afraid to let the kid do anything. You trace back and you find that this child probably had a rather soul-wrenching disability or disease early on, and this family hovers, and every little thing is interpreted, magnified. These children oftentimes are not allowed to do a lot of things because the family's afraid they're going to crumble and die. And so it's important that when you talk to them, avoid telling them that we saved your child's life. He was on the brink of death, but we pulled him through. You're going to be sorry, because from then on, the parent's going to make the child's life miserable. What is the best instrument that you have? Is the history, and telemedicine. You can still do this, which is really good. The family physician or pediatrician who gets a good history is using the very best instrument there is. And there is not one test that diagnoses disorders of behavior. And you are developing the art of medicine. It's still there with the history and physical and psychological assessments. And if you've followed families over the years like I have some for 40 years in my practice that I've raised from pups. I know what they've been through. I know their history, and it's a very, very important thing. Now I'm finishing the first one. And before I go to anything, let's look at if there are questions and answers. No open questions. Okay. So I'm going to X out of this. Let's see how we stop the share.